This is just an intraoperative photo of actually taking care of the problem through a minimally invasive technique, which was a little challenging, as you can imagine, because we had the posterior rods in place, which make it a little bit difficult. But we've identified it. I was able to take the graft out and put a little bit larger graft in and get it placed a little bit farther. It was probably a technical problem on my part in that I tried to get it really far across. This was a pretty large gentleman, and I did not get enough. I didn't get it far enough across. And in the AP image here, you can see I would rather have it about right over here. And what happened was when it kicked back, it hit that nerve root. Interestingly, intraoperatively, it wasn't on the nerve root. It just had hit it. But he'd recovered quite well after we took that graft out and put a new one in. So in summary, the minimally invasive techniques are about as safe as open procedures. There are similar complication rates. Of course, there's going to be a learning curve. And now there are a lot of, I mean, last year I was talking about some of the minimally invasive techniques, and there weren't too many people involved with it as far as the number of companies out there. But in the past year, I think we've seen a big push towards more minimal access technology. And the patients are also going to be kind of driving this as well. They're going to be kind of wanting less blood loss, less injury to the normal tissues. And with that, with more of us being trained, there should be a little bit more fellowships offered out there. So thank you.
Thank you, Trent. Aside from instability, deformity is one of the accepted complications presenting patients to us. And I've asked my partner, Dr. Wagner, to talk about a procedure which has become very popular, and that's the pedicle subtraction osteotomy. Ted?
Good afternoon. It's a pleasure to bring up a subject we haven't talked too much today about, and that is how to look at the sagittal balance, which is something that as a spine deformity surgeon I've been very interested in, and we'll try to speak around it and just make all of us more sensitive. I don't have all the answers, but we'll go from there. We're going to look at this both historically, look at the physical exam, which becomes very key, and I'm going to try to show pictures of patients because I think that's very important, and the x-ray may be less important. I would make a first statement that if we look at sagittal balance and review the literature, clearly there are some articles that show that when you are operating on patients with low back pain and deformity, the sagittal balance correction seems to be almost the most important single entity, single part of it that's going to make a difference in the end result. So I want to add on to what Dr. Mary said the last time, and that is that sagittal balance may be important in spondylolisthesis. It's certainly important in many people with degenerative disease. And these two articles both said the same thing, one by Dr. Brevin, one by Dr. Bridwell. These are big studies, 725 consecutive patients with spinal deformities, 325 had positive sagittal balance. That means an imbalance or an unacceptable posture. So the question comes up when you look at this patient, is the pain now related to the deformity or the degenerative disease? Is it due to previous distraction instrumentation in many cases? Is it due to the paraspinal muscle fatigue with this prolonged type of standing? Are the patients really upset with the ability to not have the forward gaze? Is it the thigh fatigue that comes from trying to bend their knees in order to make up for the loss of lumbar lordosis? And does this total entity become a problem for their legs? And finally, it's their image, the cosmetics of people who have been hardworking, getting around people, all of a sudden find themselves at perhaps 50 or 60, unable to stand up straight and really cosmetically handicapped. And it's very important when you look at a patient and you straighten their knees, can they really see straight ahead? This is more with ankylosing spondylitis, but it's also very important to examine the patient, and I'm going to keep emphasizing that. And remember, you have to look at their knees, you have to look at their hips, then their spine, and try to figure out where the deformity is. In that exam, you may find that this deformity really is at the cervical thoracic, or it could be pure thoracic kyphosis, like in this case, or is it the loss of the lumbar lordosis? Each one of these patients has a different presentation. Each of them is going to be confirmed with an x-ray, but your clinical impression is important. This one is probably at the thoracolumbar junction. So I emphasize the need to take a long film. And the long film has to be taken 72 inches away so that you get perspective. If you try to take, if you're handed close-up x-rays, you'll find that it will over-distort. And you'll not be able to have consistent measurements to their deformity. So and this is becoming more difficult, actually, as we go to digital. But you still can get it. We're getting it, and we just have to ask for it, and you have to really work with people because they have to average now everything from the cervical right down through the hips, and that's important. And you have to take this picture with them trying to stand up straight with their knees fully extended, because that's when they will pitch forward and you'll begin to realize the defect. So this is the ideal patient. The plumb line drops from C7, drops through the middle of L2, and you then develop a sagittal vertical axis. Now, if you take this x-ray just of the pelvis and say, well, the problem may be in the pelvis, you have a very complex way to deal with that, because we don't know where the PSIS really is, or the ASIS on a plain x-ray. So those kind of measurements have not been very reproducible. There's a lot of effort and to try to define pelvic incidence and the different angles around the pelvis, and I am very interested in it, but I'm going to tell you that it probably won't make a difference on how you operate on the patient. What really is going to happen is that you have to draw a line, and that line, these three lines, I think need to be done. This is a line that goes up the femur. So this patient is standing. It's not a free body x-ray. It's an x-ray taken with so you can see the femurs. And if you draw that line, you draw that connection, and you draw this line from along the spine from C7 down, you then have an idea of how many degrees it would take to bring the patient just to neutral. Now, you may turn around and talk to your hip surgeons and say, listen, this is a hip problem. If you can get me 20 degrees in the hips, I only need 20 degrees, 25 degrees in the spine. But somehow you have to get this patient balanced. And that's my point. My real point of the talk today is to make us aware of this sagittal balance. And I think this is a workable way to look at patients. Now, there's an important bit of geometry here that's important, and that is that if you were going to make your osteotomy here, you then have to draw a line from C7 to there, and you have a 56-degree angle that you would have to make in order to bring the head back over the femur. The lower you go, the smaller that angle is. So here at the bottom, it's 26 degrees, so a single level osteotomy at the bottom will probably balance your patient. So remember, it's where you draw that line that becomes very important. And again, you have to understand the global dynamics of it. Look for the hip flexion contractures, and look for your knees. But try to get this kind of picture, because it will help you, I think, confirm your position. Now, this is really the old-fashioned Thompson test. If you laid the patient on their back, put their legs straight, and they had to sit up in order to do that, you would approximate the same kind of line that you need. So I'm going to show a few pictures of extreme kyphosis, and these people presented with low back pain but had very significant other deformity. This happens to be a 28-year-old woman from India who came neurologically intact. Her case was that of tuberculosis. That AP x-ray on the left shows that you're looking at what appears to be almost like a CT scan because of the angle. And we have approximately 138 degrees of kyphosis. In this case, we fixed it in the bottom. We fixed it at the top. We used 4 rods. This is, on the right, is the spinal cord. And then we brought the 2 rods together, married them, and brought that 138 degrees down to 40 degrees. And the patient's back pain has been markedly improved. This was at 2 years, and this was a 12-year follow-up. So this patient no longer had back pain, but she also got rid of a huge cosmetic problem, but the risks were high. Ankylosing spondylitis makes up a significant part of a referral basis. because it's difficult in many ways. But these people will begin to talk more about stumbling. And if you examine them carefully and you extend their knees, you realize that they're really not, some of them aren't safe to walk across the street. These people have their gaze that is, becomes dangerous. And now the problem is, where is their biggest defect? Is it in their hips? Is it in their lumbar spine, thoracic spine, and neck? I think I've seen all kinds of those, and I can't predict where it's going to be. But I can certainly evaluate it. And in this case, we drew those same kind of lines. And this person has a pretty normal thoracic spine, pretty normal thoracolumbar spine, and has an absolutely fused flat back with their ankylosing spondylitis. So if you do an osteotomy, you must get at least 30 degrees of correction in order to straighten them up. And Jens is going to speak of a way that he does it, and I'm going to speak today to some extent about doing pedicle subtraction osteotomies, which is done all posteriorly, and I think has helped these patients. So this is an example where we gained, if those screws are essentially at the angle of the vertebra below, we have gained, by doing a subtraction of the pedicle, and we've gained 30 degrees of correction. Usually requires having 4 screws above, 4 screws below. And with the polyaxial screws, this operation becomes rather dynamic and easy in the final in your final correction. And so he actually reduced to 28 degrees. This is what he looked like post-operatively, and it's made a new life for this particular person. And his overall angles look quite good. The next problem is what to do for a 62-year-old patient who stands in this position and has a lot of low back pain and degenerative changes. If you look at the X-ray, she has this now combination of scoliosis and kyphosis. We draw the same lines and we realize it will take at least 35 degrees to get her to neutral, and she has 56 degrees of scoliosis. So in this case, I think one has to go in anteriorly and really does need to often almost remove radically the apex of the curve and then be able to bring about an anterior corpectomy, an extension anteriorly, and then posteriorly compress it. And so here we have corrections where we've straightened the spine in both directions. And this is a patient who had a remarkable correction. This particular patient had no complications from doing this surgery, but certainly it is big surgery, and I generally tell patients ahead of time that there's a 5% chance of a complication for every level I do. So if you do 10 levels, you have a 50% chance of a major complication. And that may be a little steep, but that's the way I've always said it. And now this patient is really erect and has gotten her this symmetry back in their waist, which is another important cosmetic problem, and is tolerating standing very well. And then finally, in the high-grade spondylolisthesis, which has been a special interest, I'll show an example of a 16-year-old. And these patients, of course, are young. They can compensate for major kyphosis. They stand with very plump discs in all the rest of their lumbar spine. They stand with all normal discs in the thoracic spine. They have hips that can hyperextend. And so they can absorb 30, 35 degrees of kyphosis and have what appears to be a normal stance. However, when you take an X-ray, you see that this patient has a very steep angle to the superior portion of 5. And if you draw a line up the back of the sacrum, there is a significant kyphosis. I use kyphosis rather than slip angle. It always bothered me a bit to use that, and so I just speak of the kyphosis. And so I think it becomes very important to actually correct the kyphosis. I think the controversy remains on how